Good evening, lecturer. This is Masanyu Annette, midwife, working with Kisoro District Local Government. I'm presenting my case of a pregnant woman who presents with systemic hypertension in pregnancy or preeclampsia. Miss AN, aged 28 years, gravida 2 para 1 plus 0, her gestational age is 34 weeks. She was admitted on 18th June 2026. Her present complaint, she presented with severe headache, blurred vision, and swelling of the feet for 3 days. History of presenting illness. Mrs. AN, a 28-year-old pregnant woman at 34 weeks of gestation, presented to antenatal ward complaining of persistent headache, blurred vision, facial puffness, and swelling of both lower limbs for 3 days. She also reported reduced urine output and occasional epigastric pain. She never gave a history of fever, trauma, and previous kidney diseases. Her past medical history, she gives no history of chronic hypertension, no diabetes mellitus. Her family history, mother has a history of hypertension, no family history of kidney disease. Then her social history, she is married and she lives with her husband. She doesn't smoke, she doesn't consume alcohol. The physical examination, her general condition is conscious and oriented. Her facial, she has facial edema, bilateral pitting edema of the lower limbs. Then her vital signs, blood pressure 170 over 110 millimeters of mercury. Her pulse is 96 beats per minute, respiratory rate 22 breaths per minute. Then temperature 36.8 degrees Celsius. On obstetric examination, there is no tenderness on light palpation. The fundal height 33 over 40, which corresponds to weeks of gestation, which is 34. Fetal heart rate is 140 beats per minute. The presentation is cephalic. The lie is longitudinal. Then the fetal movements are present. There is no enlarged organs, that is the spleen and the liver. Then we go to investigations, where we have urinalysis, which is where there is proteinuria in urine, that is plus. Then we have hemoglobin level, which is 11.5 grams per deciliter. Then there is platelet count, which is 100,000. Then we have serum creatinine 1.3 milligrams per deciliter. We can also see liver function test where there is mild. Then here the diagnosis is severe preeclampsia or pregnancy-induced hypertension. We can look at the pathogenesis or mechanism of the disease, where there is preeclampsia is the pregnancy specific multisystem disorder characterized by hypertension and proteinuria after 20 weeks of gestation. Then the pathophysiology here is 1. Abnormal placental implantation. where there is inadequate invasion of trophoblasts into maternal spiral arteries. Then the arteries remain narrow instead of dilating. Then we have another one, reduced placental perfusion, where there is poor blood supply causing placental ischemia and hypoxia. We can also look at the release of inflammatory and angiogenic factors, where we have damaged placenta which releases substances into maternal saturation. There is also endothelial dysfunction, where there is widespread damage to blood vessel lining. There is vasoconstriction, where there is blood vessels narrowing, increasing systemic vascular resistance and blood pressure. We can also look at increased vascular permeability, where there is a linkage of fluids into tissues causing edema. There is also organ damage, where there is reduced blood flow, which affects kidneys, liver, brain, and placenta. Then the clinical manifestations. Here we have the hypertension, severe headache, blurred vision, facial and pedal edema, proteinuria in urine, reduced urine output, epigastric or right upper quadrant pain, intrauterine growth restriction, reduced fetal movements, fetal distress, prematurity, etc. Then we can also look at the complications, where we have maternal complications. Then under maternal complications, we have eclampsia or seizures. We have HELLP syndrome, where there is a hemolysis, elevated liver enzymes, low platelets, etc. Then there is acute kidney injury. There is also cerebral hemorrhage or stroke. There is pulmonary edema. There is placental abruptio, leading to maternal death. Then here the fetal complications, we have premature birth, we have low birth weight, we have fetal hypoxia, stillbirth, neonatal death, and so on. Then the management. There is immediate management, where we have to admit to a high dependence maternity unit, and we monitor blood pressure regularly. We have to monitor fetal well-being. We have to monitor the fluid balance chart. Then we can also administer drugs like magnesium sulfate to prevent seizures. We can also administer antihypertensives such as nifedipine, hydroxyzine. Then we have the definitive treatment here, delivery of the baby and placenta, where maternal or fetal condition deteriorates. Or where the pregnancy reaches an appropriate gestational age. This case illustrates severe preeclampsia, systemic pathology affecting multiple organs due to widespread endothelial dysfunction and hypertension. Then the early detection through antenatal care and timely management are crucial in preventing serious maternal and fetal complications. Here the complications observed. We have pulmonary edema. The weakened left ventricle is unable to effectively pump blood received from the lungs, and as a result, blood backs up into the pulmonary saturation, causing fluid to leak into the lung tissues and alveoli. Then here this one can be manifested by severe shortness of breath, orthopnea or difficulty in breathing when lying flat, crackles on lung auscultation, then cough producing frothy sputum, then reduced oxygen saturation, and if untreated, pulmonary edema can result in respiratory failure leading to death. We can also look at the peripheral edema. Here, the right-sided heart failure causes blood to back up into the systemic saturation, increasing venous pressure and forcing fluid into the surrounding tissues. And it is manifested by swelling of the feet, ankles, and the legs, weight gain due to fluid accumulation, then the tight or shiny skin over affected area. Then this one can, in severe cases, this may impair mobility and increase the risk of skin breakdown and infections. We can also look at the acute kidney injury. Reduced cardiac output decreases blood flow to the kidneys where there is impairing ability to filter waste products and regulate fluid balance. And it is manifested by reduced urine output, elevated serum creatinine and urea levels, and then fluid overload. Progressively, kidney damage can worsen heart failure and increase mortality. There is also cardiac arrhythmias, where there is structural changes in the heart and myocardial damage may disrupt the normal electrical conduction system, where it is manifested by palpitations, irregular heartbeat, dizziness, fainting, and serious arrhythmias may lead to sudden cardiac death. We can also look at the thromboembolism, where there is poor cardiac pumping, which causes blood stasis within the heart chambers, promoting clot formation, and this is manifested by deep venous thrombosis, pulmonary embolism, stroke, and so many others. These conditions are life-threatening and require urgent treatment. And we can also look at the hepatic congestion and liver dysfunction. Here, the right-sided heart failure causes venous congestion in the liver, leading to enlarged and impaired liver function, which is manifested by hepatomegaly, right upper abdominal pain, elevated liver enzymes, and jaundice in severe cases. Here, this chronic congestion may result in liver fibrosis and cirrhosis. We can also talk about the cardiogenic shock, where there is severe heart failure can result in a critical low cardiac output, causing inadequate blood supply to vital organs. Then this one can be manifested by severe hypotension, cold extremities, altered mental status, weak pulse, and this cardiogenic shock is a medical emergency with a high risk of death. There is also reduced quality of life or functional disability. Persistent fatigue here and breathlessness can limit the patient's ability to perform daily activities, and this is manifested by exercise intolerance, dependence on caregivers, frequent hospital admissions, and this one may lead to The patient may experience social, emotional, and economic difficulties. In this patient, the most evident complications are pulmonary congestion causing shortness of breath and orthopnea. And if not adequately managed, uh, the patient is at risk of developing serious complications like acute kidney injury, arrhythmia, thromboembolism, all of which can significantly increase morbidity and mortality. Then we can also look at the signs and symptoms where we have the shortness of breath, that is dyspnea. The weakened heart is unable to pump blood efficiently, causing blood to back up into the lungs, and fluid accumulates in the lung tissues, making breathing difficult. The patient may experience difficulty in breathing during physical activities. Then breathlessness may worsen as the disease progresses. We can also look at the orthopnea, or difficulty in breathing when lying flat. When the patient lies down, fluid from the lower limbs returns to the bloodstream and accumulates in the lungs, worsening congestion. Here, the patient may experience need several pillows to sleep comfortably. Then she may also experience breathlessness, which improves when sitting upright. We have paroxysmal nocturnal dyspnea. Here, fluid redistributes into the lungs during sleep, causing sudden episodes of severe breathlessness, and this patient may experience wakes up suddenly at night gasping for air. Relief occurs after sitting or standing up. Then we can also talk about the fatigue and weaknesses, where there is reduced cardiac output, means less oxygen-rich blood reaches muscles and blood tissues and body tissues. Here the patient may experience tiredness even after minimal activity, reduced ability to perform daily tasks. We can also look at the persistent cough, where there is fluid accumulation in the lungs, which irritates the airways. And here the patient may experience persistent cough, especially at night. The patient may also produce frothy or blood-tinged sputum in the severe cases. We can also talk about the reduced exercise tolerance, where there is poor blood supply to muscle, results in decreased physical performance, where the patient may experience easily exhausted during walking or climbing stairs. We can continue with the signs where there is what the health worker can observe. We have the peripheral edema or swelling of the legs and feet. Here, poor pumping action causes blood to accumulate in veins, increasing pressure and forcing fluid into surrounding tissues. And this can be observed by seeing swollen feet, ankles, and the legs. Then pitting edema when pressure is applied to the skin. We have also raised the jugular venous pressure Here, blood backs up into the venous system due to right-sided heart failure, and this is observed by distended neck veins when the patient is sitting at a 45 angle. Then there is tachycardia. The body attempts to compensate for reduced cardiac output by increasing heart rate, which is observed by pulse rate which is above 100 beats per minute. We can also observe pulmonary crackles, and this is where fluid in the alveoli causes crackling sounds during breathing, and this can be observed by listening to crackles on the lung auscultation, then especially at the lung bases. Then we can also observe cyanosis. Here, the insufficient oxygen in the blood leads to a bluish discoloration of tissues, and this can be observed by seeing the bluish lips, fingers, or nail beds. There is also enlarged liver, in bracket hypertomegaly. Venous congestion causes blood to accumulate in the liver, and this can be observed by enlarged and sometimes tender liver on abdominal examination. Then there is also weight gain, where there is retention of sodium and water, which leads to fluid accumulation in the body, and this one can be observed by rapid increase in body weight over a short period of time. Then we can move to treatment, where we can first see the aims. Why are we treating this client? We want to improve cardiac function, we want to relieve symptoms, we want also to prevent complications, then we improve quality of life. We can also reduce hospital admissions, and we reduce the mortality rate. Then the management, we can first administer oxygen syrup. And why are we giving this syrup? The patient has shortness of breath and low oxygen saturation, indicating inadequate oxygen delivery. And this oxygen can be administered via nasal plugs or face masks. And we expect improved oxygenation and reduced breathlessness. We can also administer diuretics, for example, furosemide. And why are we giving this? The patient has fluid overload evidenced by leg swelling, peripheral edema, lung congestion, raised jugular venous pressure, and this can increase excretion of sodium and water through the kidneys. It can also reduce fluid accumulation in the lungs and tissues. And we expect reduced edema, we expect improved breathing, we expect decreased body weight due to fluid loss. We can also administer the antihypertensive medications, like the ECE inhibitors. Why are we giving this? The patient's heart failure resulted from uncontrolled hypertension. This one can dilate blood vessels. It can also reduce blood pressure. It can also decrease workload on the heart. It can also slow disease progression, and we expect improved cardiac output. We also expect reduced symptoms, then better long-term survival. Then we can go to beta blockers. And why are we giving these drugs? Here, the sympathetic nervous system becomes overactive in heart failure. This one may slow heart rate, and it may also reduce myocardial oxygen demand. It can improve ventricular function over time. Then we expect reduced tachycardia, we expect improved cardiac efficiency. Then we also expect lower risk of sudden cardiac death, etc. We can also give the aldosterone antagonists. The renin-angiotensin aldosterone system. This one may block aldosterone, may reduce sodium and water retention, may prevent cardiac remodeling, and we expect reduced edema, we expect improved survival. Then we have also the recommended non-pharmacological management, where we have sodium restriction. Here we limit salt intake to reduce fluid retention, and this one may help prevent worsening edema and pulmonary congestion. We can also limit the fluid intake, fluid restriction, and this one may help restrict fluid intake if severe fluid overload is present. And this may help reduce congestion and swelling. We can also monitor weight, daily body weight measurements, and this may help early detection of fluid accumulation. Then we can also encourage physical activity like light to moderate exercise as tolerated, and this may improve saturation and functional capacity. Then lifestyle modification. This one may be through stopping smoking, avoid alcohol, adhere to prescribed medications, also attend regular follow-up visits. Then we can move to nursing care or nursing management. Here we can monitor vital signs regularly. We can assess oxygen saturation. We can also monitor fluid intake and output. We can also observe for worsening edema or respiratory distress. We can again monitor the elevated. We can also elevate the lower limbs to reduce swelling. We can also educate the patient or on medication adherence and lifestyle changes. We also monitor daily weight. Then here we can conclude by saying that for this patient with congestive heart failure secondary to uncontrolled hypertension, the current management includes oxygen therapy, diuretics, furosemide, beta blockers, and spironolactone. Alongside dietary and lifestyle modification, these interventions help reduce fluid overload, improve heart function, relieve symptoms such as shortness of breath and leg swelling, and they may prevent further complications. Then early diagnosis and strict adherence to treatment are essential for improving prognosis and quality of life. Thank you very much for listening. I beg to stop from here. Thank you.